VMR. And today we have pleasure of having with us Dr. Victor Chedid from Mayo Clinic. He joined the Mayo Clinic in 2010 and he has special interest in inflammatory bowel disease, and he has done amazing work when it comes to intersection of inflammatory bowel disease and how the health equity comes in play when we are dealing with the LGBTQ community. So thank you for joining us, Dr. Chedid. I know it was a busy schedule for you, but still you took your time out of your clinic duties and inpatient service and came here. So we are so grateful for that. And I was wondering, Dr. Chedid, if you don't mind telling us that what sparked your interest in this field of inflammatory bowel disease, and how do you think it intersects with the LGBTQ community and health equity? Thank you.
Thank you so much for having me, and I'm really excited to do this tonight, and looking forward to a very exciting discussion with all of you here. And the time I decided to do I was still in residency. I did my residency at the University of Pittsburgh, and during residency, I knew I wanted to do a procedural specialty in internal medicine, and GI was special because in Pittsburgh we had a really big inflammatory bowel disease center, and I had so many mentors within the IBD field who I looked up to. But also, most importantly, what drew me to take care of IBD patients and want to study this condition was how I saw IBD impact people who were in our age group, that were young, who are struggling to consolidate this chronic illness that is being diagnosed with them at the formative years, whether they're in their late teens or mid-20s, and how it becomes part of their identity. And many a times I saw people who try to define themselves by their disease. And that was really heartbreaking to see, especially some people had hopes and dreams to become a pilot or a physician. And then they thought that Crohn's disease or ulcerative colitis prevents them from becoming whatever they wanted to become. And that is not true. And that's something that drew me into wanting to play a role in the care of patients who have IBD, and try to help them understand that IBD is part of you, but it is not you, and it doesn't define who you're going to become, and you can still become your authentic self, whatever you want it to be. You can live up to your full potential, and that's something that I keep near and dear to my heart when I see patients in clinic every day. But also recognizing that IBD is diagnosed at a young age, right? And those are the formative years. It's at the same time somebody is trying to come to terms with their gender identity, sexual orientation, and it is a hard world out there. The world is cruel to anybody who's an other. So the LGBT community, unfortunately, is othered, and to think about that you have IBD, so you are othered for having IBD, and you are othered for being part of the LGBT community. The interplay between both these identities has a big impact on patients, and that's something that me and many others who treat patients with IBD are recognizing, that we have to create those safe spaces for the LGBT community who has IBD. I don't want them to be delaying their care because they're afraid that us as healthcare workers might discriminate against them for their identity. I don't want them to come to us when they're sicker, when their disease could have been treated at an earlier stage, but they delayed it because they're afraid we're going to be discriminatory against them for their gender identity or sexual orientation. And I want to understand better the impact of gender affirming care on IBD, and how that might play a role on the disease phenotype and severity, and how we can better understand all of this so we can guide our patients better. So sorry, that was long-winded, I know, but that's my answer.
It was worthwhile, Dr. Chedid. Thank you for sharing such a touching message. And I hope that we will carry forward your message. And when we are trying to help our patients who are young, who have IBD, and who are especially from LGBT community, hopefully we can deliver the same care as you are delivering. So thank you. And now I will ask my dear friend Jimena to straight away dive into the case. We cannot wait. You can briefly introduce yourself, Jimena, and let's start with the first selling point. Thank you.
Hello, everyone. It's a pleasure to be here again doing my favorite thing, which is presenting cases here at the VMR. It's so nice to meet you, Dr. Chedid, and thank you for giving us that good reminder of how we do need to care about patients as a whole and not just the diseases. So if you're all ready, we're going to start with the case. We have today a 30-year-old male who consults due to acute odynophagia, dysphagia, and epigastric pain.
Wow. What a blockbuster start, Jimena. So, Dr. Chedid, I wanted to know that how do you approach dysphagia in general, and how odynophagia, if somebody has, how does that change the equation for you?
Yeah, that's a interesting presentation. And in that case, we're thinking about dysphagia. And when you think about dysphagia, you got to clarify from the patient's history better what type of dysphagia this is. Is it esophageal dysphagia, so further down, or is it oropharyngeal dysphagia, so difficulty from transferring food bolus from the mouth back to the esophagus, or is it difficulty of the food passing from the esophagus down to the stomach? So that would be something I would think about in getting a clearer history from the patient. The second thing I would think about is the acuity. Is this something that has just happened, or has it been going on for a while? So in this case, you're mentioning acute odynophagia, dysphagia, and epigastric pain. So acuity matters in terms of trying to determine what the etiology is and to build your differential diagnosis. Third, you're thinking, is this painful dysphagia or is it painless? Because that also determines if what the etiology is and helps us narrow down our differential diagnosis. And then when you're trying to determine the different types of dysphagia, if it's dysphagia that is esophageal, you'd think about, is it solid food dysphagia, liquid dysphagia, or both? Because that also matters for the etiology, because you're trying to think, is it a motility issue where the esophageal motility isn't working and not allowing anything down? Or is it obstructive cause of dysphagia, or mechanical obstruction that's resulting in the dysphagia, where they can pass liquid but not solid? And then the other thing you would think about is, if it's solid, liquid, or both, is it progressive, or is it from the initial presentation directly related to either solid, liquid, or both? So progressive makes you think of a process that's growing, such as esophageal cancer. And these are the things that I would think about.
Perfect. Thank you so much for sharing your approach, Dr. Chedid. I love how you put the time concept and how the solid and liquid dysphagia differs. Jimena, we are ready for more.
Mhm.
Great. So telling you guys a little bit more about the patient history. 3 to 4 weeks ago, he started with a band-like pain that was located kind of in the lower chest, upper abdomen. It was radiated to the back. He had one episode of loose stools, but otherwise he referred normal bowel movements. He never had emesis, nausea, headaches, lightheadedness, weight loss, fatigue, shortness of breath, or fever. He developed a dysphagia to solids and liquids 2 weeks ago. The night prior to the admission, he was eating cereal, and that caused the sudden right abdominal and right flank pain. And he said it was 10 out of 10 of intensity. And through the course, the patient had this intermittent pain that prompted him to go to the ED multiple times. Because of the location of the pain, he was always cataloged as having chest pain. So every time he went to the ED, cardiac workup was done, and the EKGs and the rest of the cardiac enzymes were always normal.
Wow, what a interesting piece of HPI. And whenever we have like this sudden onset abdominal pain, it often scares like how to manage the situation in such dire conditions. So Dr. Chedid, I was curious to learn from you that whenever you are dealing with a sudden onset severe abdominal pain, then what are some of the critical must not miss diagnoses that we should look for, and any particular examination findings that can guide us in framing our differentials?
Okay, yeah. So this adds a lot of perspective right now to this case. And so let me just, do you mind the question you're asking me about upper abdominal pain?
Sure, any abdominal pain in general, Dr. Chedid.
Okay. So in the setting of approach to acute abdominal pain, things that we should not miss. First of all, it depends on the age of the patient, age of presentation of the patient. Younger folks versus older folks, you're worried about slightly different things in the setting of acute abdominal pain. So that's one thing. Second, you're thinking about do they have any underlying conditions, such as if a patient has a history of ulcerative colitis or Crohn's disease. I'm thinking with my IBD hat, so sorry about that. But if somebody has an underlying medical condition that could get exacerbated and give you an acute presentation, you would worry about, for example, with ulcerative colitis and severe ulcerative colitis, you'd worry about megacolon or toxic megacolon. In an acute infectious process such as C. diff, you would also worry about toxic megacolon. With Crohn's disease or ulcerative colitis, you would worry about an abdominal, colonic or intestinal perforation as an acute cause for acute abdominal pain. Now, more common things that you would think about are location of the pain. So that's important. So if it's, for example, right lower quadrant pain, or if it starts in the epigastric area, then radiates to the right lower quadrant, you're starting to think, could this be an acute appendicitis process? Versus if it is a right upper quadrant pain radiating into the shoulder blades or in the right upper quadrant area, you would think about something like acute cholecystitis. Mid-epigastric radiating into the back, you would think about acute pancreatitis, for example. So that's when I'm starting to build the differential with the severity of the pain, location of the pain, the underlying conditions that the patient has. And then I would think about the alleviating and relieving factors for that pain. That's also important. Additionally, I would think about other extra systemic symptoms associated with the pain. So for example, you would think about, do they have any associated fevers or nausea or vomiting, or which I believe Jimena alluded to with this patient. And again, on physical exam, you asked about that too. On physical exam, you would look for, first of all, general appearance of your patient. Do they appear toxic, or do they appear comfortable or well appearing? What are the vital signs of that patient? That's also important. Are they hypotensive or tachycardic or hypertensive from the severity of the pain? Then you would approach the abdominal exam with trying to see if the patient has any bowel sounds on exam. And when you use your stethoscope, sometimes that can be helpful, because if they have peritoneal signs, even laying the stethoscope on their abdomen can make a patient jump in pain. So that's if there's any abdominal perforation or peritoneal irritation. Just laying the stethoscope on their abdomen can be quite irritating and cause exacerbation of their symptoms. Then you start with the rest of the physical exam with the palpation of the abdomen. So you're trying to identify where the tenderness is at. So you're trying to see if there's tenderness to palpation in a specific spot in the abdomen. Sometimes if the patient has peritonitic signs, they'd be tender all over their abdomen, versus if it's something related to their biliary tree or gallbladder, they would have more of a tenderness in the right upper quadrant. You're also looking for guarding with the abdomen, where a patient would have either voluntary or involuntary guarding, where they're trying, whenever you press on their belly, they either their abdominal muscles tense up, they either or they push you away, or their abdominal muscles involuntarily tense up. And then there'd be rebound sign or rebound tenderness, where when you press in, the patient will have tenderness, but it's worse when you press out. That's called rebound tenderness. Another thing to look for is the Murphy's sign, which is when you press in the right upper quadrant area and ask the patient, they would be tender, and ask the patient to take a deep breath in, they would stop mid-breath due to the severity or intensification of the pain. That could be due to gallbladder irritation. Another thing you look for is in the right lower quadrant area, they might have focal tenderness there. That's if you're looking for acute appendicitis. But also there are certain appendiceal inflammatory signs that you can also attempt. So they would have tenderness in the McBurney's point down in the right lower quadrant, or the opposite side would, if you press on the opposite side in the left lower quadrant, they would be tender in the right lower quadrant. That could be another sign of acute appendicitis. And then you can also try the obturator sign. These are like going into further signs where you bend their hip flexor and then push towards inwards and then outwards with their thigh, where that could trigger irritation of the appendix and can be positive in these signs.
Wow, Dr. Chedid, I remember my anatomy classes now with all that rich examination findings that you shared. Thank you so much. And now I'm excited to see that what Jimena has to share with us regarding the examination findings and how we can utilize the pulse which you shared with us to move ahead. So Jimena, I'm excited to know more about the past medical history and the examination findings.
I totally agree with you, Curtin. That was a very thorough reminder of the things that we have to look for in physical exam. I'm going to give you the physical exam in a while. With past medical history, we don't have any. He doesn't have any chronic conditions. past surgery history, he had an appendectomy 20 years ago. In social history, he was born in Haiti. He came to the US 20 years ago. He denies use of alcohol, tobacco, or IV drugs. We did get some travel history from him that was remarkable. He went to Haiti in January of this year, and then to the Dominican Republic in April. And then moving forward with the physical exam, his blood pressure was 114/74, pulse 89, respirations 18. He was saturating 95% at room air, and his temperature was 36 or 97 Fahrenheit. His appearance, he appeared comfortable. He was in no pain when we went to see the patient. He had no oral lesions, no pain to neck movement, no lymphadenopathies. His cardiovascular exam was unremarkable, as well as the pulmonary. In the abdominal part, he had no tenderness to palpation. We couldn't find any hepatosplenomegaly. His extremities, it was unremarkable too, and neurological. The patient was alert and oriented in person, time, and place.
Perfect. Thank you so much, Jimena, for giving us a thorough physical examination. So now, Dr. Chedid, since we have the past medical history, even some interesting travel history, how do you factor that into the examination findings and what data we already have?
Interesting. So from what we're seeing is that the patient does not appear toxic based on the physical exam. And it sounds like the abdominal exam was relatively reassuring in this situation. Now, I sometimes whenever I hear that somebody's sharing with me a travel history, I try to see if this is pertinent to the clinical presentation. And one thing I would wonder in the setting of acute dysphagia, Odynophagia, and epigastric pain, could this be some infection that they acquired while they're traveling abroad? So I would put the travel history as a thing that I would park in the back of my mind and worry about as I'm digging into the history. I also was thinking about potentially drug use or alcohol use, which the patient denied, so we can move on from that. But when I don't want to anchor on the travel history, but one thing you would wonder in somebody who went to Central America, you would wonder about Chagas disease, for example, which could be an infectious process that could cause mega esophagus. So that would be something I would put on my differential, but I don't want to anchor there. Yeah, what else were you gonna ask me?
Oh no, that's it, Dr. Chedid. We got your approach, how you factor in the examination findings and the travel history, and now we can get some basic labs from Jimena.
Sure.
So for the basic labs that we got from him, his white blood cell count, it was in 6. It was normal differential, hemoglobin 13, hematocrit 39.8, and platelets 224 K. His CMP was normal. His LFTs were normal too. And just to be on the safe side, we also got a troponin, which was normal. He got a CTA chest and abdomen, and this study reported an 8-centimeter mass or complex fluid collection within the posterior wall of the distal esophagus with esophageal thickening, adjacent fluid, and paraesophageal lymphadenopathy. There was also seen a peripheral enhancing 4-centimeter fluid collection continuous to the mass.
Wow.
Okay.
So now the plot thickens with the esophageal thickening, it looks like. So, Dr.
Mhm.
Chedid, now how are we moving forward with this piece of data?
Mhm. So the plot does thicken here, and again, the lab seemed to be unremarkable. I was going to ask for a lipase given the epigastric pain radiating to the back, but the CT scan does not show any pancreatic um, abnormalities, it sounds like. And now we're dealing with this 8 centimeter mass and complex fluid accumulation at the posterior wall of the esophagus with esophageal thickening. I'm rereading it just for all of us and for me also. Adjacent fluid in the paraesophageal lymphadenopathy, peripherally enhancing 4 centimeter collection contiguous with the mass. So I would wonder what sort of mass. I would go visit with radiology when I see such a CT scan to have them review the imaging with me. Because again, I am trained to look at imaging to the best of a gastroenterologist's knowledge, but a radiologist can answer a few questions, try to help us build the differential. So I usually would go visit the radiologist in their reading room and sit with them and review such an interesting case. I would wonder about what the etiology of this mass is. Is it liquefied or is it a solid mass? Is this could this be um, like an abscess that's paraesophageal versus a malignant mass versus an infectious process that's resulting in that mass. So these are things I would be thinking about. I would also think about the possibility of a distal esophageal perforation with an esophageal leak. So that would be one thing I would wonder about. So that's where my mind is at right now. Another thing you would think about is that you're saying that he had a couple of weeks of 2 weeks of dysphagia to solids and liquids. So one would wonder if this patient had any achalasia with distal GE junction, high IRP and distal GE junction. And that led to potentially esophageal perforation with a leak. But I'm just thinking out of the box here a little bit.
Perfect. Thank you, Dr. Chedid. Then before we get the next piece of data, I wanted to ask one question that now we have a young person who had this dysphagia for 2 weeks and now presenting with acute onset of abdominal pain. So
Yeah.
is there any way in which we can link the findings which we had on CT scan with the acute worsening of the clinical status, and what are the ways in which we can do that?
Yeah. So I'm thinking the same way too. I'm trying to link because especially when somebody has no past medical history and they're young and they're had a symptom that started a while before and now it has worsened and we have CT scan findings. I rarely think of like multiple rare things happening in one patient. So I try to do the Occam's razor, if I may, and just clump together different things to try to make sense of it in a unifying diagnosis. So that's what I'm trying to do here as well. And yeah, so I try to piece together what has been going on for the past 3 to 4 weeks with the dysphagia, with the band-like lower chest, upper abdominal pain. Now I'm wondering if this is something that has been slowly growing over the past 3 to 4 weeks that has now suddenly worsened to the degree where it's causing that acute exacerbation or acute presentation. So yeah.
Perfect. That does help a lot. Thank you for clarifying, Dr. Chedid. Yes,
Absolutely.
Zimena. Yeah, thank you. Yes, Zimena, we are eager to learn more.
Wow, Dr. Chedid, you basically say everything that we were thinking of, and I'm just going to give away this small hint because you mentioned radiology, and we did go with the radiologist to try to understand a little bit better this mass. After we went with radiology, they decided to perform an upper esophageal ultrasound, and it revealed an extrinsic narrowing of the esophagus. It was seen a large mass-like lesion adjacent to the esophagus with associated cystic area. Both were separately sampled, and it was sent the studies to cytology and to microbiology. And the report said that the appearance was most suggestive of a periesophageal abscess and a phlegmon.
Was most associated, you said?
Yeah.
Okay.
So because we were thinking about this, the patient was initiated on antibiotics, specifically cefepime and metro, thinking about an abscess. And the culture came back and it revealed staph aureus. It was MSSA with another moderate mixed organisms that were resembling, to the esophageal flora. So that's what we have right now.
Yeah. So goes back to where would somebody get MSSA into the paraesophageal area, and where would you get mixed esophageal flora into the paraesophageal area? It must have come from the esophagus. So that's what you are worrying about. So in this case, you're wondering an abscess, did it come from contiguous spread, or did it come directly from the esophagus? And in this case, I'm wondering if this is an esophageal leak. So that's something I would have, before doing the upper EUS, which is I think GI does, not radiology. In our sense, we do endoscopic ultrasound, but before doing that, I would have done an upper GI series. Is that something that was considered? Because the upper GI series with contrast, and usually I would use gastrographin when I'm worried about an esophageal perforation rather than barium, because barium is irritating to the mediastinum and can cause mediastinitis. So you do not want barium when you're worried about an esophageal leak. So you would do a gastrographin esophagram, and that would be to confirm the suspicion for an esophageal perforation. But an endoscopic ultrasound is also very helpful in this case because it helps you get a sample from that collection.
Yeah, I think that that was the thought process, to just get a sample of the mass, because it was considered to get those series, but it wasn't done. They just prefer to go with the ultrasound.
Fair enough.
Perfect. So, Jimena, you can tell us more that how the case evolved.
Sure. I'm just letting you know that I'm going to tell this aliquot, and after that, I'm going to reveal the original or the diagnosis that we were thinking about. And so to tell you a little bit more about the patient course, even though we were thinking about this mass possibly being an abscess and a phlegmon, despite the antibiotic therapy, the patient reported no improvement. He was more than a week with this antibiotics, and he just remained the same. Every day he just complained about the pain, not being able to eat anything. So at this point, they decided to repeat the CT chest because of the lack of improvement. And the CT chest revealed a similar appearing heterogeneous solid and cystic mass lesion within the mid and the distal esophagus, with new small bilateral pleural effusions. And they found a little bit of an increased mediastinal fat stranding, and they were concerned for mediastinitis. Because of this concerning findings on the CT, it was also thought that we should get cardiac surgery involved in this case, because we didn't know if we were going to actually need to open up the patient and take out that mass. Unfortunately, this aggressive approach also was considered because of the complaints of the patient, and he didn't want to have a G-tube placed. And he was also in a lot of favor of just like doing the surgery, thinking about infection or inflammation, or if this was primary esophageal neoplasm.
Wow. So, Dr. Chedid, at this point in time, it looks like that we had one of the sinister findings on CT scan, something which looked like abscess. We tried to treat it, but looks like that clinically patient is not getting better. And we have additional mediastinal findings on CT scan. So at this point in time, how would we change our differentials and any particular management considerations, keeping in mind that patient could deteriorate?
Yeah, really great point. So I wanted to go back to the previous point, which part of you're worried about esophageal perforation, you're suspecting it, you treat it as such. And so in such a case, I wanted to ask you guys, how has he been eating, or has he been prevented from eating? Because in such a case, you should, if you're worried about a perforation, you should consider making the patient MPO, because with continuous eating, that continuously feeding that abscess or through the perforation. So that's one important point that I forgot to make. And whenever you see esophageal perforation or suspect it, you have to treat for possible mediastinitis. So you would consider a broad spectrum antibiotic, but also there are certain populations that you would also consider antifungal coverage in them. And those are patients who are either immunosuppressed, elderly, and folks who have HIV, or other reasons for covering with antifungals, like prior surgery, prior hospitalization. In this case, I don't know if you would have met the criteria for antifungal coverage in a setting of esophageal perforation, but I would have definitely kept him MPO, considered TPN nutrition, total parenteral nutrition, and had a high suspicion for perforation and treated it as such. I'm wondering if with the cefepime and metronidazole, if that would have been sufficient coverage versus broader coverage, such as piperacillin tazobactam. I think they would cover this similarly. I would involve infectious disease to help me, to be honest, as a GI doctor here. And then I'm now wondering why he's not getting better. He has mediastinal fat stranding suggesting mediastinitis. So again, what making me worry about the source control, that the source control is not sufficient. And then there's the cystic mass-like lesions. Is this at all the abscess, or is there an underlying malignancy there that we should continue to worry about, such as lymphoma, or yeah? So these are the things that I'm thinking about right now.
Perfect. So, Jimena, you have all of us at edge of our seat to know how the case evolved. So please enlighten us.
I love all the thoughts that you have been discussing, because that's exactly what we were thinking of. Definitely, they widen the antibiotic coverage. They did add the antifungal for some days, and they decided to do a repeat imaging. It was very coincidental, because the day that the imaging was set to be done, the patient miraculously woke up with no pain at all. And we were all stunned, because after 12 days of being in the hospital, since he was admitted to the ED, the patient had no pain, and he was able to tolerate all the food as if nothing had happened. And we got an MRI, So the MRI revealed a large, predominantly posterior esophageal intramural hematoma in conjunction with a lower right paresophageal contained perforation. And it was thought to be caused by an esophageal dissection or an occult underlying lesion denominated intramural esophageal duplication cyst. So this pathology needed us to follow the patient with some imaging after the inflammation was controlled to actually be able to determine which of the two were, if it was either the spontaneous perforation or the duplication cyst. But either way, both of the occurrences were extremely rare. And what prompted the symptoms of the patient was superimposed infection on this pathology that probably he had for a long time and we just didn't know.
That's very, very interesting. It's a really good case and many teaching points that we can get out of this.
Yeah, it was, I think that the clinical improvement plus the MRI were what was needed to be able to tell the cardiothoracic surgery that it was not going to be needed. They're consulting, because the morbidity, of putting through a very young patient through opening his sternum and exploring the esophagus would have been very high. And after talking with the cardiothoracic surgeons, they were also relieved that they didn't have to operate the patient, because if it was a duplication cyst, they tend to bleed a lot and they can have a lot of complications during the surgery. So we were just so glad that the patient didn't need to go through that.
And did you get a sense of why he suddenly got better? Like, how did you explain that?
The following studies did reveal that the inflammation was a lot less, and radiology was key to this case. We were going almost every single time to the department to get a more thorough reading from the imaging. And we were discussing about the timing where you do images, that sometimes it's very important to think about it, because you can get a process right where the inflammation is at their most. And that's what we also thought that it was happening with the suggestive mediastinitis, sorry, that
That's
the patient have had. So that was also a good thing to reflect on this case when you're doing imaging. What are you expecting to find? And if the time where you're doing the imaging is going to have like a key impact on what you're thinking about the patient might have.
That's right. Yeah. That's such a great case.
Perfect. And in general, Dr. Chedid, I was curious to know, because this is something which is kind of unusual and unexpected for many of us who are present here. We haven't seen such esophageal duplication cysts that commonly in our practice so far. So we wanted to know from you that how common are the duplication cysts and what are the common clinical features that they can present with?
Really good question. I don't know if I have the answers to that. I don't want to sound stupid. I've not seen it once. And I think last time I read about it was for boards. So that was a while back. So I don't have an answer. Maybe Jimena would have a better answer for us.
Jimena, do you have any pulse for us? Any take-home points?
Well, I think that my takeaway points from this case is one, just always consult when you don't know. Like leaning on other colleagues can be very helpful, especially when it's not your expertise area. And I would say that second, just keep always your differential very broad when you're unsure. And it's always good to just go back to the presentation of the patient to just think about what are the things that initially I didn't consider? Because at the beginning with this patient, we anchored a lot in this being just an abscess. But when it was not improving clinically, that's where all of the alarms hit, and we just had to go back and think, like, what did we miss? Because originally I was in the ID department when I saw this case, and that's why we were consulted. And it ended up being a non-ID pathology to treat. So just always have your differential broad if you feel like the presentation of the patient is not matching what you would expect with the treatment.
Perfect. And also, when I wanted to know that how was it like for you to take care of this patient? Because as it seems like the patient unfortunately had to go through a lot of complications. So how were you kind of managing that part of the care?
Personally, for me, it was hard because I would go to see him every day, and I would go hoping that he would feel better. And every day he was just like, I feel the same. I feel the same. And I was fortunate enough because he had a good attitude about it. He was just like, no, I trust that you guys are doing what it's needed to be done. But then there was a certain point where he was also feeling like he was stuck. And that's why he was refusing other interventions like the G-tube placement, and he was very adamant of wanting the surgery. And it was hard to just try to explain to him, all of the people involved, ID department, GI department, CT department, the primary team, to make him understand that if we weren't taking that aggressive approach, it was in his best interest. But he was a very, very nice patient because he always kept a good attitude. So I think that from that side, he made it a little bit easier for me.
Truly a touching story. Thanks for sharing that with us, Nimena. And before we wrap things up and ask Tansu to share wonderful teaching points, Dr. Chedid, our last question would be, what are some of the key takeaway points from this case, and how we should make sure that we do not miss this again in the future?
Absolutely. So again, this was a common presentation of a rare condition. So the take-home points that I would focus on are more about the presentation and how it was managed rather than what the ultimate diagnosis ended up being, because the ultimate diagnosis is quite rare. So the important points I would think about are, first of all, how to approach dysphagia and how to get a proper history for dysphagia. And the second point is how to approach a patient with acute presentation that we talked about. We reviewed features that you should not miss on the differential diagnosis of abdominal pain, but also physical exam findings that you should look for. Thirdly, is to avoid anchoring bias, and in this case, the Haiti and travel history was going to sway us in one direction, and it had nothing to do with the story and the presentation. So make sure you're not falling for anchoring bias, and to keep a very broad differential. And I was taught by one of my role models from Pittsburgh. She always used to tell us, there are things you park in the back of your mind and you worry about them. And then there is a working diagnosis that you're working through, and you're treating the patient based on your working diagnosis. The things you parked in the back that you are worried about, you can bring to the forefront if what you're doing for the patient isn't going right or it's not working. Then you start bringing back pieces from the history that you parked in the back of your mind to try to make sense. Why is it, to kind of troubleshoot, why isn't what we have been doing working, and what are we missing? So it's always important to have humility and be humble when you're approaching any case, because you have to treat the patient acutely and make sure they're getting better. But if what you're doing isn't working, don't keep pushing or banging on the same wall or barking up the wrong tree, if you can say that. So again, always be ready to go back to the drawing board, rethink the case through, see what is not working and why is it not working, and try to make sense of it, just like you did in this case. And always keep friends from the multi specialties. So if you were going to be a general internist, you're going to need all the subspecialties as your friends, so that you can always run cases by them and work together as a multidisciplinary team to get the right care for that patient. You need the radiologist, you need your gastroenterologist. So always keep friends around you, and recognize that everything you're doing is for that one single patient as a multidisciplinary team.
Such a fantastic way to end our VMR. Thank you so much for encapsulating and summarizing everything for us, Dr. Chedid. We appreciate you taking time for us. And now in the end, I will ask my dear friend Tansu to share the teaching points for this case.
Sure. Thank you so much for the great case, Mena, and great discussion, Dr. Chedid. So just echoing your words, we first define the problem because it's more important than speculating about the diagnosis, just framing what the problem at hand is. We started off with patients, one of the chief complaints, dysphagia. We asked a couple of questions just to understand his dysphagia better. First, we were curious about the type of dysphagia. Is it oropharyngeal or esophageal? Is it acute or chronic? Is it painful or painless? And is it, if it's esophageal, is it to solids, liquids, or both? And is this dysphagia progressive or stable? And then we looked at must not misdiagnoses of the acute abdominal pain. And in that, we had to consider patient's age, underlying conditions, location, radiation, severity, alleviating and relieving factors, and associated systemic symptoms. Also, in the physical exam, there were a couple important points that we had to look for, like the general appearance of the patient, vitals, bowel sounds, and peritoneal signs. The patient also had travel history, but we said it's good to keep this travel history in mind without anchoring too much on it, because the chief complaints may or may not be related to the travel history. And then our patient was not improving on the treatment that we were giving to him. And in that, we had to consider a couple points too. So is it the wrong bug? Is our coverage enough for the type of infection that could possibly be impacting our patient? Is the source control enough? And is this a problem caused by a non-infectious cause? So those were my teaching points. Thank you so much again for the wonderful case and discussion.
Thank you. Thank you so much, Tansu. We appreciate your time and efforts. And I also want to thank my friend Shema, who was helping us scribe the case for us. Jimena, thank you once again for once in a lifetime kind of case. We will never forget the duplication cyst part. And Dr. Chedid, again, thank you for laying down the framework for us, that it's more about the approach rather than the diagnosis. And we will remember the take-home points which you shared, that think about the management in these cases rather than the final diagnosis, which was rare to begin with. So thank you so much, and we would love to see you in the future again.
I would love to come back. This was really fun, and you made me go out of my comfort zone. I see a lot of IBD, so I haven't been dealing with a lot of dysphagia recently, so I was very excited for this, and thank you so much. This was so fun, and I'd be happy to come again.
Thank you. Bye-bye, friends. See you tomorrow for another VMR.